Next slide, please. So the question says a middle-aged man with chronic obstructive pulmonary disease, hypertension, and osteoarthritis who lives 4 hours from the hospital expresses his concern on clinic attendance. He is adherent with his medications. The first question is, what is telemedicine and options for telecare? And what advice will you give him in case he has an emergency? Now, looking at this question, this patient has 3 chronic conditions: COPD, hypertension, and osteoarthritis, which may actually make it difficult for him to be regular on clinic visits, and hence the need for telemedicine. And so what is telemedicine? Telemedicine can be defined as the diagnosis, treatment, and monitoring of patients remotely using telecommunication technology. There are actually various types of telemedicine, as we shall see later, and we have the asynchronous type, synchronous, as well as telemonitoring or remote monitoring. What are the options for telecare? Telecare are simply technologies that can help patients to stay independent and safe at home. This include discrete devices that can monitor health, and patients can usually use that to call for help if anything goes wrong. Next slide. So types of telecare equipment include what that this patient will particularly need, because patient could have a fall, for example, and so the patient may need like a movement sensor to detect if the patient has fallen out of bed. So that may have to be put in place. Fixed alarms, such as pull cords in the bathtub or bathroom, portable alarms to wear on the wrist or around the neck, pill dispensers to release medication. Next slide, at the appropriate time, and trigger an alarm if it isn't removed from the dispenser. And then also gas shut off devices or fire detectors to reduce the risk of forgetting to turn off a gas ring or fire. So these devices are usually gotten in developed countries either by contacting their local council and requesting for a care needs assessment, or it can be purchased privately. Telecare Services Association can also help in this regard by providing a list of telecare companies to choose from. But actually, this form of service is more in advanced countries. It's actually a novelty in this part of the world. Now, what advice would you give him in case of an emergency? The first thing would be to try to look at a hospital nearest the patient's home and try to register the patient there, as well as register the patient with an ambulance service, and also visit the nearest hospital as the physician in charge of the patient to see the doctor there, to also discuss with the doctor in case of any emergency, so that the doctor can always contact the index doctor at the center where he's being managed for further management. Then patients can be given emergency drugs in case of an emergency. For example, if he has an exacerbation of COPD, the patient can be taught on how to use a nebulizer and can be given nebules so that he can use if there's a need. Then remote delivery of an array of healthcare services using telecommunication infrastructure as a definition of telemedicine. And then another factor that should be considered will include the level of the education of the patient, the level of exposure to use of equipment such as laptops, phones, as this will determine the form of telemedicine that the patient will benefit from. So if this patient, for example, is not used to laptops, the patient may be taught on how to use maybe voice notes if that's what the patient is used to. That will be the form in which the patient will use to communicate with his physician. And then patient can be educated on what defines an emergency. If he's breathless, if he has a fall, or if there's sudden weakness, because the patient is hypertensive, so the patient could have a stroke. So the patient will be educated such that if this occurs, he is supposed to contact the nearest hospital. And then from there, the hospital where is nearest to him will contact the index hospital, and then the further management will be continued. So I will want to talk briefly on telemedicine. Next slide, just briefly. Okay, so telemedicine is more than a distance. Next slide. The definition evolution is actually a Greek word meaning distance, and medicine derived from medere is a Latin word meaning to heal. The definition here is the one I gave previously, defined as diagnosis, treatment, and monitoring of patients' care remotely using telecommunication technology. Next slide. Next slide. And the evolution of telemedicine technology. It started from the point-to-point system, point to multi-point system, and multi-point to multi-point system. So the point-to-point system, so one patient end connect to one specialist doctor just within the hospital. Then a patient can connect to more than one specialist in the point to multi-point system. And then the multi-point to multi-point system is several patients and simultaneously connect to different doctors and at different hospitals at different geographical locations. So the telemedicine system actually consists of an interface between hardware, software, and communication channel. Next slide. Next slide just talks about a brief historical perspective. You can look at this later in order to save time. Next slide. Next slide. Next slide. Okay, what are the objectives of telemedicine? Is to enhance citizens' equality in the availability of specialized medical services by bringing these services to remote primary health care centers, to promote the proficiency of physicians and other healthcare personnel, to reduce the waiting list in specialized healthcare, to save money. Next slide. And so types of telemedicine, like I said earlier, we have the asynchronous type, which is also known as the store and forward. So here, the event is not happening real time. And so examples under this will include the use of emails, text messages, and voice notes. Then the next one is real-time interactive service. So here it is real time. The patient actually will be communicating with the specialist. And examples under here include the use of Zoom calls and Skype. And then we have telemonitoring or remote monitoring, which is the third type. It's usually getting physical characteristics of a patient. For example, diabetic patient, usually used for patients with chronic conditions, diabetic patients, patients with heart conditions. For example, in diabetic patients, the use of chips that will be able to monitor the blood sugar. A device is actually connected to the doctor's device in the office. And so the blood sugar of the patient can actually be monitored. So that's remote monitoring. Next slide. So as I said earlier, the store and forward is a method that is common in the field of dermatology, radiology, and pathology. And with proper structure and care, store and forward telemedicine can save time and allow medical practitioners to serve the public with their services more fully. Next slide. Just as I've said earlier, real-time interactive service will include an interaction between the patient and the specialist happening in real time. So I talked about um, Zoom calls, I talked about Skype. Other examples will include even home visits. Next slide.
Chief, you have 1 more minute.
Okay, so next slide. So also we have the advantages of telemedicine. Next slide. The advantages of telemedicine. We can read it up. Next slide. Uh, Next slide. Please. Then what are the barriers to telemedicine? Okay, perspective of medical practitioner that doctors are not fully convinced and familiar with e-medicine. Then patients fear and unfamiliarity. Then financial unavailability. Then lack of basic amenities. Next slide. Technical constraints. Next slide. Okay, next slide. So what is the importance of telemedicine? It helps patients in rural and distant areas to avail timely consultations of specialist doctors without going through the ordeal of traveling long distances. Then with the help of this, a specialist doctor can advise a doctor or a paramedic at the patient's end on the course of treatment to be followed, just like in this patient. And he can even guide the doctor in case of a surgery. So in conclusion, telemedicine needs to be implemented carefully and managed well. And then the impact of telemedicine on healthcare structures can be significant. However, there are also concerns about liability, confidentiality, and other policy, regulatory issues, and pricing. It's important for us to know that telemedicine cannot be substitutes for physicians in rural areas, especially in developing countries where resources are scarce and public health problems are in plenty. Thank you very much. These are my references.
Wow, thank you so much, Dr. Jimmy, for that beautiful, lucid presentation. Thank you, Dr. Joe, for sharing. Okay, so now we'll take comments and questions from the participants first. And let's keep the thanks coming on the chat. I think it was a very lucid presentation. Okay, so it was a very nice one. Dr. Dan says well presented. Thanks, Chief. Okay, I just wanted to add that for I think patients that's we should use telemedicine for our patients like the one painted in this scenario, patients who are very well motivated, and their adherence. I think such patients will benefit from telemedicine, so that anytime you have contact with such patients, can counsel the patient on this condition, how to prevent, prevent the exacerbations. For instance, like this patient, the patient in the clinical scenario, given the clinical scenario, the patient is very well motivated. So such a patient will benefit from education, on prevention, smoking cessation, since he's very adherent, check his inhaler technique anytime you have contact with him, and then maybe he will even benefit from literature material so that he can know more about the condition, and then be taught how to recognize an exacerbation. You should even have simple tools like the pulse oximeter to check his pulse himself, can count his heart rates, so it will counsel if your respiratory rate goes beyond 24, if your heart rate is more than 90, if you start having increased sputum production or coughing and worsening dyspnea, then you should know that maybe you have an exacerbation, and tell them what to do. Just like you said, provide him with a nebulizer, nibbles, salbutamol nibbles, and then you should be able to recognize when he has increased sputum volume and purulence. Maybe you already have an action plan with him, so that he'll know which antibiotic to take. He'll know that maybe he can take prednisolone for not more than 5 days. Just like a well-documented written action plan between the doctor and the patient, and then when to recognize symptoms that will need him to come to the hospital or go to the nearest facility or call the ambulance service he's registered with, like you said. So it was a nice one. Thank you so much for the presentation. Okay, so I don't know. I can't see any electronic hands up. It was a beautiful one. Let me go to the chat room. So everyone is applauding you for the beautiful presentation. Thanks so much. Dr. Blessing Amadi says, thank you so much for a beautiful presentation. Are telemedicine services paid for? What category of patients can it not be used for? Okay, please, you want to react to that?
Hello. Okay. Well, let me start from the last question. The category of patients that telemedicine cannot be used for will be patients that are really very sick, patients that have emergencies. I believe for such patients, they just because there will be no time for anyway. I think I don't know, but I just thinking that a patient that is because of the different forms of or different categories of a patient. Well, let me just say, I think it can be used for everyone. Can be used for everyone. I don't know what the chiefs in the house have to say about it. The aspect of paying for telemedicine is actually paid for, but who pays it is what I don't know now, because it's not common in this part of the world. It's new to us here, but over there they have some telemedicine services providers. Like I said earlier, those people will be the ones to sort it out. And there are some, so they can either sort it out from their telemedicine services provider, or they can also purchase some of these things privately. For example, some of those telecare products, equipment I mentioned earlier.
All right, thank you so much. Okay, let me share my thought on that, although I stand to be corrected. Okay, maybe patients who are not motivated, patients who are not learned enough to use the electronic gadgets, some people that cannot use the phones, the current social media platforms, and like you said, patients who are just too sick to be that actually need hospitalization. Okay, so let me take more comments. A lot of thanks, more thanks to you on the chat from Dr. Rita, Dr. Musa, Dr. Lawrence. And then Dr. Yaya says, well done, my chief. It's a good one. It's also important for the doctor to have the contacts of the close relatives and caregiver for proper communication in case of some acute emergencies that could arise in which the patient may not be fully conscious to directly communicate with the patient. Wow, thank you so much, Dr. Yaya. Okay, so in absence of more comments, I'll hand over to our teachers. Mark, Mr. Bell.
Hello. Thank you, Dr. Jimmy. That was okay. Thank you. That was a fair attempt at that question. Thank you so much. I don't know if okay, Chichitusa, go ahead.
Okay. Yes. Good morning, Dr. Christopher.
Good morning, sir.
Well done, presenters. Actually, I wasn't there from the beginning of the presentation. Came in at the tail end when they asked you the question about who can't you get more. Yes, I think Dr. Kelly had mentioned a few. Yes, if the person is not technically vast in the type of telemedicine you are using, but even that is being overcome over time with simpler forms of telemedicine, and even AI is helping to sort out some of those lack of technical skills in people. So, of course, we know basically we can't use telemedicine to prescribe. Prescriptions are off when it comes to telemedicine. So anyone that needs to a new prescription, okay, you can't do that over telemedicine. So you need to get the person to come in to be assessed properly. Yes, critically ill patients in life-threatening positions you shouldn't waste time on telemedicine. The person should come into the hospital as quickly as possible. We do know that telemedicine it can be interactive or it can be asynchronous. That means asynchronous means it's not happening real time, stored and then sent forward. Okay, so sometimes telemedicine may delay. So you don't want to use that for critically ill patients. Of course, there's a lot of things going on now with a branch of telemedicine which is called telemonitoring, in which you have devices that can give doctors real-time results of either examination findings like blood pressure or even investigation findings like blood sugar, real time. That's not telemonitoring. So the scope is increasing. And of course, less and less people are out of it. So we're bringing as much people into it as possible. Of course, but lack of access to the internet, lack of access to facilities, IT facilities too, could also limit the use of telemedicine in certain areas. Yeah. So those are just things I just want to pitch in, but well done.
Thank you, sir.
Mark Christabel.
Yes.
Can I go on?
Yeah, Dr.
Okay.
Kelly, just move on. I think maybe Dr. Christopher is adding to the network.
Okay. Thank you, sir. All right. Thank you so much, Dr. Ojo, for helping us out this morning. Thank you, Dr. Jimmy, for a beautiful presentation. And thank you, everyone, for your comments. Dr. Yaya, Dr. Bessie. Okay, so Dr. Wasinda, thank you for understanding. Please, you can go ahead.
Good morning, ma.
Please, you can go ahead and share. Go ahead.
Oh. Okay, thank you, sir. I'm trying to share. Yeah, good morning. Please, am I audible?
Yes, Chief, I can hear you. I can hear you. I see your slides too. Yeah, go ahead. You have 10 minutes.
Good morning, my facilitators. Good morning, teachers, senior colleagues. I'll be taking practice question 2. My name is Wasinda Francis Omar. The question is a clinical scenario of increased mortality of patients presenting with upper GI bleeding in your hospital. Question A says, what would you do? Question B, mention the steps you would take. C, mention how you would take data in this condition. D, list teams involved. E, list headings of your reports to the hospital management. For the first question, what would you do? I'll set up a committee involving all stakeholders and do a clinical audit on the increased mortality of patients presenting with upper GI bleeding in the hospital. The committee will audit the structure on ground, facilities for resuscitation, upper GI, endoscopy and banding, also the availability of trained staff, health services, emergency drugs at the pharmacy, etc. Mention the steps you would take. So the first step I'll do is identification of the problem. This will involve choosing a topic from the question. So the topic is going to be the increased mortality of patients presenting with upper GI bleeding in the hospital. And a team will be created that will comprise all stakeholders, including the hospital management, all the clinicians and ad hoc staffs that will be involved in the managing patients that come with upper GI bleeding. And this committee will agree on objectives. Just give an example of some of that. It could be to determine the characteristic of patients presenting with upper GI bleeding in the hospital. And the objective could be to compare would include to compare emergency response to upper GI bleeding in the hospital against standard practice, to determine the effectiveness of endoscopic intervention in stopping upper GI bleeding in the hospital. Then we'll now review evidence. What's the existing clinical protocol? How has upper GI bleeding been managed in the hospital? Then the next step will be to definition of standard. This will be using evidence-based guidelines available, or we could also use protocols from bigger centers that have better outcome than ours, those that have less mortality and morbidity among their own patients. And then we'll now obtain ethical clearance to go ahead with the study. Then the next step will be data collection. Preferably, this would initially involve doing a pilot study to have an idea of the best, with the approach, the best sample size, to have an idea of the best way to go about the whole study. Then the next step will be data analysis. This will discuss findings, make recommendations. Then we'll present these findings to back to the committee. Of recommendation and changes. There are many ways to take data, but however, I will choose to do probably a questionnaire-based data using a well-structured questionnaire. The questionnaire will have the following components. One of the components would be to know the characteristics of the patients, gather detailed information on patients with upper GI bleeding, including their demographics, comorbidities, presenting symptoms, vital signs, laboratory results. And then the questionnaire also assess the knowledge of the signs and symptoms of upper GI bleeding among the caregivers. Also assess the skills of resuscitation among these caregivers, the steps of the ABC, the appropriateness of the interventions to be used, and then also assess the availability of resuscitation materials in the emergency unit, cannula, giving set, etc. We'll also assess adequacy of blood services and access to these blood products, especially during the emergency hours. We'll also assess the adequacy of staff, evaluate the staffing level, availability of specialized services like in the interventional radiology operating rooms during emergency hours. Also, the questionnaire will assess the availability of endoscopic services, and then the ICU services. How accessible is it, the staffing and the equipment available? D question says, I should list the teams involved. The teams involved will be the gastroenterology team, the medical emergency team, the hematology team, the nursing team, intensive care unit team, pharmacy unit, surgical team, the hospital administration and management, and also the quality improvement and patient safety team. The fifth question says, you list the headings of your reports to the hospital management. So after taking the study, the report will have the following headings. One, there will be an executive summary. This will give a brief overview of the audit. Then an introduction that will give a background and context for the audit, including audit objectives. And then the methodology that was used to describe the audit design and approach, data collection method. And then the findings will now present the audit results. And then also the analysis and interpretation, all the root cause analysis, all the gaps that we discovered, implication of these results on patient care and outcome. And then you will now also give recommendations. This would be specific recommendations, actionable recommendations that will improve clinical practice and enhance patient safety. Then the action plan, that would be based on assigning responsibilities, timelines to those action plans, the resources that will be required, and support monitoring and evaluation strategies. Then a conclusion too. So I just want to go briefly over our clinical audit. Audit in healthcare is a process used by healthcare professionals to assess, evaluate, and improve care of patients in a systematic way. Audit measures current practice against a defined standard. It forms part of clinical governance, which aims to safeguard a high quality of clinical care for patients. There are the various definitions, one of which is clinical audit is a quality improvement process that seeks to improve patient care and outcomes through systematic review of care against explicit criteria. Where indicated, changes are implemented and further monitoring is used to confirm improvement in healthcare delivery. Then why do a clinical audit? Because one, clinical audit identifies and promotes good practice. It leads to improvements in patient care. It provides information about the effectiveness of a service. It highlights problems and helps with solution. It also improves teamwork and communication. So this just talks about the clinical audit process. When you are asked to do a clinical audit, actually you audit either the aspect of structure, either the process or the outcome of that's what you select, and then you systematically evaluate against explicit criteria. So this is the clinical audit cycle. The first is identification of problem, definition of standard, data collection, data analysis, implementation of these changes, and then re-auditing. So what are the qualities of a good clinical audit topic? It addresses a known quality issue. It addresses an important area of practice. It has the potential to achieve and improve quality of patient care. It addresses an area of clinical certainty and consensus. It will use explicit audit measures and has clinical support, and it involves self-audit. So after a clinical audit, how do you disseminate your results? The standard way is to present it back to the local or institutional clinical governance meeting, giving them a feedback of the result. But you could also present it as a hospital report. You present it at conferences. It could also be used as a local or institutional guideline, and then also in peer-reviewed journals. So this is just a table showing the difference between clinical audit and research. Clinical audit attempts to find whether best practice exists locally. Then a research attempts to define best practice. A clinical audit usually involves setting standards, while a research involves testing hypotheses or implementing new methods. Clinical audit does not involve intrusion beyond normal clinical activity, while a research may involve intrusion beyond normal clinical activity. And then ethical clearance approval and patient consent is needed when the public is involved directly in clinical audit, while ethical control is a must. You must do it when you're doing a research. And then clinical audit involves selecting a representative sample, but not allocating patients randomly in groups. However, in research, it involves allocating patients randomly, depending on what kind you're doing, maybe involving both treatment and a placebo group, depending on whether it's a randomized clinical trial or depending on the type of research you're doing. And then it may involve collaboration with patients, while research may involve collaboration with manufacturers. Thank you for listening. I acknowledge slight inputs from Dr. O. Ojo from the updates, TIOG, Omoli, and Dr. Elhatu. Thank you very much.
Thank you so much for that beautiful presentation, Dr. Wasinda. Okay, so now we'll take comments and questions from the class. Dr. Ibifiri is saying thank you for the beautiful presentation. Then if you want to make a comment, you can raise your electronic hands. Okay, so Dr. Yaya is saying thank you, Dr. Wasinda, for the lucid presentation. Your objective must be SMART. You must be specific with the components you want to audit, whether the structure, process, or outcome. Okay, you later corrected your statement on requiring ethical clearance. Thank you. Good one. Thank you so much.
Thank you very much.
Yeah, I can't see any hands up. Okay, well, Christabel.
Hello, Dr. Kala, can you hear me now?
Yes, I can hear you now. Thank you, ma.
Okay, thank you. So, Dr. Wasila, thank you. I don't know if any of our teachers have any comment, but I also want to be sure that it's not my network. Please, which part of clinical audit did you audit in this particular case? Was it the process, the structure, or the outcome? I don't know if I got that.
Yes, ma'am. I chose to audit the structure.
Okay, Dr. Chituzan is up. Let him. Chief Chitusa, go ahead. Chief Chitusa. Dr. Kala, can you hear me?
I can hear you, ma.
I don't know why Chichitu is not responding. Dr. Ramigus, please go ahead, sir.
All right. So, thank you, Dr. Wasinda, for that beautiful one. In fact, when you were presenting, I felt you had a very good grasp of clinical audits. All right. Just some little tweaks here and there. Please, it's important to note that ethical clearance is the exception, not the rule in clinical audit. Normal clinical audit, you do not need ethical clearance, unlike research, okay? So, like when you were discussing, you say you get clinical audit, so you don't need it, okay? Just maybe very few situations, but normally if they ask you if you need clinical audits, if you need ethical clearance in clinical audits, the answer is no. You don't need it, okay? All right, so that's that. Then when you are told to outline the process, there are these processes that we normally see. The first one is usually prepare and plan, okay? And I don't know, I think I've forgotten but the first process is usually to prepare and plan. It is in prepare and planning that you now talk about forming your team, all those ones, all right? There are usually 5 steps, okay? I'm just trying to remember them now. It's been a long while that I read through it. So, but the first one is usually prepare and plan.
Dr. Ramigo.
Yes.
So prepare and plan. Yeah,
yes.
how you doing now?
Yeah, please go ahead.
Prepare and plan, pick a standard, then compare
standard.
the standard with what you're doing currently. Of course, preparing and planning, you'll have decided whether you're auditing structure, process, or whatever. So you're comparing the standard with what you're doing currently. Then you try and upgrade whatever you are doing. And then you improve what is going on. And then, of course, sustain.
You sustain the re-audit, yes.
So the last and then re-audit.
Yes. So, but I love the fact that you pick structure. The only thing is that when you were now preparing your questionnaire, you were now straying a little bit into process. Okay. If it's structure, you have to, stay exclusively on the structure. Now you can finish auditing your structure and your structure is fine. Okay. That may suggest that the problem is not structure. You now go to process. Do you understand? So, but that's why it has to be smart. You don't just take everything at once. You might miss out on certain things. So you do one. Most people like to do process, but structure is also fine. Structure and process are usually the best to audit. Outcome is usually a little bit less. It doesn't really have so much for it to offer, but structure and process. Okay, so please, if you choose structure, you have to stay on the structure. If you go to when you are preparing your questionnaire, some of the questions we're looking at process, okay? Like maybe know-how of the staff. That one is already a process, okay? But if it is structure like availability of blood bank, availability of staff, availability of endoscopic equipment, all those ones, availability of emergency medications. So all those are structure. Even the building itself, do we have a good A&E? All those things are the structure that you are auditing. But if you want to know how the blood pressure is being checked, how the knowledge of those that are attending to them, the nurses, do they know what to do? All those ones are now the process. Okay, so you dabbled a little bit into process when you were talking about your questionnaire. So you have to stick to the structure that you wanted to audit. Okay. So, but I loved your definition of clinical audits. It was a very beautiful one, and you really did a very good job on it. I think that's what I want to say. Thank you.
Thank you very much, sir.
All right, sorry, I got logged out and I came back in. A network issue. Yes, so well done to the speaker. Dr. Remigos has touched many of the things I wanted to touch, particularly that you were dabbling into process and structure at the same time. And many a time the examiners are actually listening out for, whether you can tell the difference between structure and process. Okay. A good way to remember it, okay, is imagine cooking a meal. Okay.
Yes,
Every ingredient you're going to use and every equipment you're going to use in the kitchen to cook that meal is structure. Okay. So the pots, the pans, the raw materials you bought from the market, and everything, the spices, all of that.
The cooker and the cook.
The cooker itself, exactly. And you, the chef, you're all structure. Okay. So you can arrange all those things and put it on the counter. Yes, you can see your cooker, you can see your ingredients, you can see yourself, you can see the cookbook, okay, that you are, perhaps using to cook the meal, to come up with the recipe for cooking the meal. The cookbook is structure, okay? Now, process is one, how you use that cookbook, how you use the ingredients, how you use the cooker, how you use the water, how you use everything. That is process, okay? And then outcome is basically the people that are eating the food that you have prepared. Do you understand? Many outcomes because auditing is basically for if you build a new unit or you have a new dialysis unit and you want to know the impact of that unit on the people.
Chisa, Chichito, I'm barely hear you.
And
It's bad.
Am I breaking up?
Yes.
Bad, Abby.
I thought it was bad. It was. Sir?
If she should just go and climb a mango tree.
I'm trying to look for one that's high enough. It's pawpaw tree I'm on now. Maybe I should switch to mango. All right. Can you hear me now?
Yes, we can.
It's better now, Abby. Okay. I had to step outside. No, my network has been crap since the beginning of the week. Yes. So as I was saying, I said the outcome is basically what result from when you're using that particular facility. So usually when you're trying to audit something you've added to the system, like if maybe you got a grant to start an endoscopy suite in your center and you now want to know the impact on your clients, okay, whether it has improved their outlook, then that is when you now audit outcome. So if you're painted the scenario that, you just started a new center of this, doing this, or you just built a new pharmacy or a new something, or you started treating a new type of patient in your center that you didn't used to treat before, then it's outcome that you would audit. Okay, so that's how that looks like. Now, I have a question for the speaker. Why did you decide to go do a clinical audit and not a risk assessment or risk management? Hello, speaker there?
Yes, sir.
Yes, why not do a risk assessment here? Why did you decide on a clinical audit?
Chief Shit, you're a wicked examiner. Chai.
No, I just want to know because you see, this question is I'm just projecting myself that if I was the one that said this question. One of the things I'll put there is why your choice of what you want to do. Because here they say, how do you want to tackle the problem? So why did you decide to do clinical audit? And when you're preparing and planning for a clinical audit, one of the things you have to do is to ask yourself, will a clinical audit solve my problem? So would a clinical audit solve this problem, or will it have been better to do a risk assessment?
Okay, thank you very much, sir.
Yeah.
Why I chose to do a clinical audit, the moment I saw the question about this, the outcome is that there's a problem with increased mortality with patients that present with upper GI bleeding. So I immediately thought if the right protocol is being used, if standards are being maintained, there's a chance that this mortality would be reduced. So, and the way to compare to know if standard is being done at our facility is to do a clinical audit. And while doing the clinical audits, if I choose to either audit the structure process, there are some elements of risk assessment that also occur while doing the process.
The risk assessment is different. Though. Risk assessment is different from a clinical audit.
Yes, sir.
So you can't do both. Which one are you doing?
Clinical audit, sir. I felt
I agree with you that the clinical audit, but I want you to convince me that the clinical audit is the best way to solve this problem.
Okay, so I just felt if standard protocol is being upheld, if standard practice is done in our facility, it's expected that mortality for upper GI bleeding should be reduced. That's why I felt the clinical audit.
Yeah.
Yes, sir.
Now, well, you're almost there. The truth of the matter is, when you're doing a risk assessment, the problem is not the lack of structure, the lack of process, all of that. The problem may be that there are medical errors or there are things going wrong with how you are using whatever is available to you in the center. Do you understand?
Yes, sir.
So risk is more like you're blaming. Doing a risk assessment, it's more like you're blaming the hospital or or how the hospital is structured, so to speak. But when you're doing an audit, it's like it's not really your fault, but you're trying to see how you can improve it or make it better. So if the question had started with the commissioner in your state or the minister had come to your center saying, despite the fact that I have given you all the things you require to sort out this problem, people are still dying. Then it now becomes a risk assessment. Do you understand?
Yes, sir. Sorry,
yes, but if you are the one asking yourself the question that, look, these patients are dying, do you understand? You're asking yourself, nobody's blaming you per se. Then you're doing more of a clinical audit. Now, it is also possible that nobody is blaming you, but you still need to do a risk assessment. And that would happen in a situation where maybe you discovered that patients perhaps were getting a complication from your management. For instance, patients on the ward are picking up nosocomial infection. Then it's a risk assessment. Or patients with upper GI bleeding are having endoscopy and dying during or following the endoscopy. Then it's a risk assessment you will do. Okay. But if people are dying from upper GI bleeding, okay, in your center, you're noticing that they are dying, then it's more of an audit. It's not that you're doing something that is leading to their death. So you're trying to figure out how best to go about it. Now, it is possible to do your audit and now realize that you need to switch or do a risk assessment, but you complete your audit and then you go and do your risk assessment when you have discovered something that may be a point of risk in your center. Do you understand?
Yes, sir.
Yeah. So that's what I just wanted to point out, because every time I keep looking at these things, many of these questions they bring out are, gray area between risk assessment and audit. Okay, so you have to, especially when they're talking about mortality, there's a gray area between the two of them. So it's important to know when to implement whichever. Yes. So well done.
Thank you very much.
Over to you, Dr. Christabel. Yes.
Oh, thank you, sir.
Sorry
Thank you.
for the bad network.
Hello, can you hear me?
We can hear
Yeah,
you,
go
sir.
ahead, Dr. Remington.
Yeah, so another place that one can think about risk is if, for example, maybe an establishment, people are getting injured, maybe due to things that you're not sure of, but you're seeing a lot of people are getting injuries. There are some negative events occurring. I want to find out what exactly is causing this. So that might be a good point to use to do risk assessment. Okay? So you think that all the equipment are there, everything you need are there, but yet certain things are happening, certain negative consequences are happening. You want to know what is causing these negative consequences. So risk assessment seems to be a better tool to use there. Thank you.
Thank you, sir.
Thank you, sir. Thank you. Dr. Fatima, you can go ahead, please.
All right. Thank you very much to both presenters. My comment is regarding the step in clinical audit, measuring performance. I think you just, I don't know if you really mentioned that. To measure performance involves data collection, and your data is not targeted only to the patient, but also to the doctors, the nurses, and other healthcare workers involved in the management of the patient, because you want to assess what exactly is happening. Then after you collect the data, you compare what you are doing in the hospital to the standard, meaning you see how much of the standard are you doing? Are you doing maybe 40%, 50%, or 60% of the standard way to manage this patient? So this is where you identify your lapses. You understand? If you are doing only 40%, then it means you are not doing good. So then you identify your problems. That is where, after which you improve your performance. So after you analyze it there, you measure what you are doing, then you improve your performance. So that's what I wanted to add. Thank you.
Thank you, ma'am.
Thank you, Dr. Fatima. Thank you so much. I think Dr. all those their hands are up have spoken. I don't even know if our chief have any other thing to add before we close the class. So thank you, Dr. Wasida. Thank you. Dr. We appreciate your time, the time you took to get this presentation ready. Thank you so much.
Thank you very much.
The other lady that presented,